Yes. Hello, good afternoon, ladies and gentlemen. You're welcome to this eco session, the 99th. And it is a running platform. We are here ready to run with you. So, for the sake of waiting for other members to join us, maybe we can give it the next 3-5 minutes. Encourage your friends, your workmates to join in this eco session so that we can run together this very interesting case. You do not want to miss it. You do not want to miss the presentation, to miss the experts' opinion. You do not want to ask the question that you want to ask on this case, and also give us your opinion on how you feel about this case. So maybe you can be patient for about a few minutes as we invite people, also invite your friends to join us that we start together. Thank you so much. All right. So my name, I'm Dr. Joseph Imsiwe. I'm emergency medicine resident at Makerere, year 3, and I'm honored to chair this eco session, the 99th of it. So today we have a panel of experts. I will allow them to introduce themselves, then we start. Maybe I can start on my right.
Good afternoon, dear audience. Thank you so much for tuning in this afternoon. I'm called Dr. Lawrence Segawa. I'm a third-year resident in pediatrics and child health, Makerere University. It's a pleasure to be here today.
Thank you so much. On my left.
Good afternoon, our audience. I'm Dr. Anne Kabuna. I'm an emergency physician, and I'm glad to be here.
Thank you so much, Dr. Anne Kabuna. We have another expert online, Dr. Abeso, and we would like to hear from her. Let her introduce herself, and then we go on.
Good afternoon, everyone. Hello, good afternoon, everyone. I'm called Abeso Julian. I'm a pediatrician from Valley Hospital. Thank you. Hello.
Excuse me, Dr. Abeso, we cannot hear you.
She was actually mute.
Yes, so we have Miss Bessie. She can also introduce herself if she's on.
It was loud and easy from the audience.
Hello, can you hear me?
Yes, we can hear you now.
Okay, I'm called Abeso Julian. I'm a pediatrician from Valley Hospital.
Thank you for being part of this. Then Miss Bessie, if she's on, she can also introduce herself. Yes, she will join us around the way. So today we are looking at a case approach the child with chest pain. So we shall be looking at the different aspects, the case presentation and different experts. But before we start, everyone could be having the expectation. So this is at the time where we expect the audience to tell us, go into chats and write what do you expect to get from this session, so that the presenters can focus on that, so that it becomes profitable to you as an individual also. And I will pick about 2 members of the audience to unmute and they tell us what they expect. So you can raise up your hand, then we allow you unmute, then you can tell us what your expectation of this session is. Yes, do that very fast so that we do not spend a lot of time. Thank you so much. I'm going to pick about a few members so that they can unmute and they tell us what the expectation is. Mr. Akujiziwe Ivan, the last one. Down. Yes. Yes. Mr. Akujiziwe Ivan, you can tell us what do you expect from this echo session? And as he prepares to tell us what he expects from this echo session, Mr. Alex Nderema can also tell us what he expects from this session.
Hello. Good afternoon, everyone.
Good afternoon.
This is Akuziwe Ivan. I'm a medical clinical officer from St. Elizabeth Community Hospital, Kamuli Buwalula Mitiana. So for me, I would like to get more guidance and knowledge on assessment, emergency assessment of children with chest pain. Thank you, everyone.
Thank you to the presenters you've had. Make sure by the end of this session, Mr. Ivan has run the assessment of a child with chest pain. Another person that we have picked on. Mr. Alex Nderema.
Thank you so much, Doctor. I was muted. I'd love to learn about when you are presented with a child with chest pain. As the initial presenter already proposed, what is the emergency assessment of that child who has presented with chest pain, and what are the basic management they start with approach to manage that child who has presented with acute with chest pain, and which examination parameters are we looking at? The basic investigations. Children tend to be considered unique as adults. So which quick investigation strategies are we looking at? Yeah, basically. Thank you so much.
Oh yeah, thank you so much for that input. And I can see radiographic investigations done from the charts. I can see nursing care plan, especially for unconscious patients, and many more. So keep the expectation coming in within the charts section. We shall keep following them up. And for the interest of time, ladies and gentlemen, we are 3 minutes behind schedule. And allow me introduce to you Dr. Lawrence Segawa, then will take us through the case presentation today. Pay attention, make sure that you hear step by step to avoid unnecessary delays. Dr. Segawa, you're welcome.
Yeah, thank you so much, Dr. Bisiwe, for the opportunity. Once again, you're most welcome to this presentation. There have been quite a number of expectations, and I believe by the end of the session, we will have met all the expectations. I want to present you a very interesting case, and I want you to be attentive from the very beginning because it's an interesting one. Briefly, this is a MR, a 9-year-old, who was admitted at our acute care unit on the 21st of this month at about midnight, and presented with 2 days history of a cough that was associated with piercing chest pain. radiating to the back. They also had generalized body pain, including long bone tenderness pain and difficulty in breathing. They had been fairly well for the last 9 years without any admission. When we did a primary survey, we noticed actually their airway was parted. But however, they were in severe respiratory distress with a respiratory rate of 46 breaths per minute. Remember, this is a 9-year-old, so that is really very high. And then they were saturated between 75 to 80% on room air. They had vesicular breath sounds and vasocrepitation. In their saturation, they were tachycardic with a respiratory rate of 116. However, they had warm periphery. The pulse rate was strong and regular. The normal heart sounds 1 and 2 heart. There were no added sounds. Under disability, they were left with a GCS of 15 out of 15. The pupils were equal and reactive to life. They had a soft neck. They had normal tone and reflexes. There were no focal neurological deficits. On exposure, we had a temperature of 36.6. They were sick looking, like we already said, they were in severe respiratory distress. However, there were no rashes, no wounds, or any therapeutic scars.
Yes. From the history and primary survey that we've had, what do you think they are the most emergencies? So we are going to have a poll. You see them on your screen. Quickly pick what you think the answers are, and you shall see at the end of the polls what the right answers are. Don't fear, just pick the answer as fast as you can. Thank you. Thank you, thank you. Yes, for emphasis, there is a poll that will appear on your screen. It's a question with answers. So tap, read the question and tap on the answer that you think is most suitable. Just that will take about 1 minute, then we shall continue with our presentation. So do that so that we move on with our presentation. Thank you. Oh, yes. We can continue with the presentation and we see what the right answer was.
Yes, under threats, realized that this child was in severe respiratory distress. We earlier had said he was saturating at 75% to 80 of room air. And this was actually an impending, under the risks, you realize that we had an impending respiratory failure and then neuromuscular fatigue. This child was also hypoxic, evidenced by the tachypnea and then the respiratory distress. The associated risk here would be hypoxic cardiac arrest.
Yes, based on the above information, what are your management options? If you're the clinician on duty and you've had that history and examination findings, what would be your management options? So this is another poll. Please quickly choose what you feel is the best option. Do that very fast. Meanwhile, if you have any question regarding anything, please do not hesitate to text it. Go into chats or in Q&A, then you ask your question. We have experts, Dr. Anna Kaguna, the emergency physician, she will be answering the question. If your question is directed to a particular expert, still you can make that very specific. And if you want to really speak out your question, you can raise your hand at the end of the presentation, we can pick you. Keep on filling the poll, read the question and pick the answer that fits best. Yes. Yes, 90% have chosen mechanical ventilation and oxygen therapy. Let us see.
All right. Well, yes, from our findings, we realized that the immediate intervention, the people who chose mechanical ventilation as portal, and this child actually needed mechanical ventilation. Then for the case of the hypoxic cardiac arrest, we needed to we actually connected them to oxygen via non-rebreather mask to raise their saturations to about 94%. Because you notice they came at 70. So what happened in the emergency department to stabilize this patient? We have to put the patient on oxygen, 15 liters per minute by non-rebreather mask. We gave the patient oral morphine, 15 mils of 1 milligram. This is oral morphine, which is green for pediatrics. It's usually 1 milligram per meal. And then we also gave them IV paracetamol, 450 milligrams. We also transfused, this child was 30 kilograms. Yeah, so based on the dose, we usually give morphine at between 0.3 to 0.5 mils per kg. So we used the 0.3 mils per kg. We transfused with packed red blood cells at 10 milligrams per kg. So we gave 300 mils. And then the patient was well positioned in spine, in bed at 45 to relieve the distress. Yeah, in summary, like we said, there was generalized body pain for 3 days, and the signs and symptoms was a cough for 3 days, there was chest pain for 2 days, and then difficulty in breathing for 1 day. This child had no known allergies. Prior to coming to the hospital, they had given the child oral paracetamol tablets. Past medical history, this was a newly diagnosed sickle cell disease patient. This diagnosis was confirmed on this admission, and this was their index admission. They had had a meal on 21st before admission, and then the events leading to the presentation, we noticed that the child had a cough for 3 days, and prior to admission, they were also passing tea-colored urine. In our secondary survey, the relevant positive, the child was sick-looking. They had moderate pallor with a tinge of jaundice, and the respiratory system, they were in severe respiratory distress. They were hypoxic, but they had bilateral echo air entry. They had vesicular breath sounds with basal crepitations. In the cardiovascular system, the only significant thing there was the tachycardia. The musculoskeletal system, they had obvious frontal and parietal bossing with long bone tenderness. In our relevant negatives, we didn't have cyanosis. We maybe have expected this child to be cyanosed. We didn't have a history of a fever. We didn't have cold extremities. We didn't have a distended JVP. We were also not hypotensive. Our abdomen was non-tender. And then we also didn't have joint swelling.
Yes, from our primary survey, sample history, secondary survey. Now, if you tie them all together, and you're the clinician on call, what do you think could be going on to this patient? What do you think could be differential diagnosis? So you can write them up in chat, and then we see what Dr. Segawa has for us. So go ahead in chat and write down your differential diagnosis. Yeah. Yeah. Expand it. Maybe Mr. Ainom Douglas, from all this presentation, what do you think are your top differential diagnosis? And Miss Aida Namugumia. Oh. Dr. Aida Namugumia could also give us what your top differential diagnosis would be, and then we continue and see what Dr. Segawa has for us. Hold on. Keep those differentials coming in. Dr. Winfred Nanyombi could also give your contribution. What do you think are the differential diagnosis? But the rest can keep typing. Type them in the chat, then we continue. Oh yes, acute chest syndrome in sickle cell disease, sickle cell disease with vaso-occlusive crisis, acute chest syndrome, pneumonia, vaso-occlusive crisis in sickle cell disease, acute chest syndrome, SES, severe malaria. Yes, I think the majority are thinking in the line of acute chest syndrome, vaso-occlusive crisis, pneumonia, and sickle cell patient. Thank you so much, everyone who has participated. I think we are all correct. Other answers are correct.
Yes.
Can give us the more correct options.
Like he has said, there are no wrong answers in adult education, but they are usually the most correct answers. So we try to categorize for us the different differentials that we are thinking about. In terms of vesicular, we had anemia, we had a vaso-occlusive crisis, and I'm glad that majority of people were able to tell that this was acute chest syndrome. And in the other infectious, we're thinking about pneumonia, is malaria, sepsis. Then trauma, it could probably have been a blunt chest trauma with a pneumothorax or a hemothorax. And autoimmune, because we had also joint pains, you could think about juvenile idiopathic arthritis, or it could be a systemic lupus erythematosus. Metabolically, you definitely think about derangements in the electrolytes, could be an acid-base imbalance. And in terms of when we are idiots and the patients are pathetic, probably could be idiopathic interstitial pneumonia. Neoplastically, you can think about leukemia, you can think about a lymphoma, it could be an osteosarcoma with a lung mets. Yes. So all these are possible differentials. Yes. So, but let's go ahead to see how we investigated our patients so that we can zero down to possibly the cause. When you realize these are the investigations we did. Full blood count, we had an HB of 6.2. This was anemia. We had a platelet count of 504. We had a white cell count of 34.9. This was a leukocytosis. But specifically, our absolute neutrophil count was 29.3. We had a neutrophilia here. And then our MCV was 89.7. Our malaria smear was positive. Our random blood sugar was 5 millimoles. And it's our liver function test. We had a high bilirubin level. You can see our both the direct and the total were raised. Our ALT was raised, but our AST was within normal range. In the electrolytes, we had a bit of slightly raised creatinine. The urea was within normal range. Our potassium was normal, and then our sodium was normal. This child had a blood group O rhesus positive.
Oh yes, before you is an X-ray. So that was the X-ray that was taken. Look through it with the history, tie them together, and tell us what do you see in the X-ray. Yes. So the answers are before you. You don't even have to overthink. Choose what you think is the correct answer, and at the end of the quiz, we shall know what was the most correct answer. Yes, keep those answers coming in. The quiz that is on your screen is just meant for you to choose the most correct option. Then we shall continue. If you have other interpretation of the X-ray that you feel was not included within the options, feel free to type them in the comment section. Let's hear your opinion. If your answer is not included, write it in the chats. Yeah, 17% think this is a normal X-ray. 11% think, yeah, see that hilar lymphadenopathy. 13 say this is ground glass opacities. Then 58% say this is subsegmental opacities or consolidation. So let us see, Dr. Lawrence, which one of them is the most correct answer?
Thank you so much, audience. You're amazing, and I think we have some radiologists in the audience. Yeah, but if you realize our X-ray was actually well taken, they will not give you the details, but let's just go to the lung pathology. You see that our lungs are quite obvious, but you notice that in the middle lobes, you see a bit of opacities. There, you can see that we have people who talk about segmental opacities as spot on. It's not very clear. I don't seem to appreciate the ileal lymphadenopathy here. But if you look at both the right and the left side, move the cursor around there, you see those white. Yeah, we ideally know that the lungs are air is supposed to be dark on X-ray. Okay, so in normal lung, we expect it to be dark all through, but you see those white infiltrates. Okay, you see those white infiltrates there. And then we also see a few on the right side, yes, where the cursor is. Yes. So there was pathology here. We can continue. Yeah, so what were the diagnosis? We now zeroed down to the key things that we have. We had an acute chest syndrome. In view of the presentation, the history, you've noticed that this was the 9-year-old, and it's the first time we are diagnosing Graeme with sickle cell disease, so there was a bit of Graeme diagnosis. We also had generalized body pain, so we vaso-occlusive crisis setting in there. And when we also did their malaria slide, we noticed that they had malaria. So complicated malaria is one of those that we highlighted, and then they also had a severe pneumonia.
Yes. In light of the above diagnosis, what are the top 3 priorities for management of acute chest syndrome? So on your screen, you will see a poll, a question with different answers. Go ahead and choose the most correct option. And in about a minute, Dr. Sega Lawrence will tell us which one is the best option. So let's do this very quick so that we understand this case better.
There are many. There are many.
Wow, that audience is amazing. They are quite engaged. I like this. Yes.
What are the 3 top management priorities for acute chest syndrome? We just need one answer like this. Choose the most correct option. Option A, bronchodilators, corticosteroids, and diuretics. And 10% are saying, yeah, that's the best option. Option B, oxygen, fluid therapy, blood transfusion. And 81%, they're thinking, yes, that's the option. Option C is vasopressors and histamines and beta blockers. Actually, there are people who are thinking this could be a magic option that could change this child's life. Then option D, we have anticoagulants, thrombolytics, and analgesics. And about 6% are saying, yeah, this is the right option, maybe given that this person is in pain and all of that. But Dr. Segawa is here for us to tell us over the 4 options, which one is the best option.
Okay. Yeah. So thank you, audience, for your contributions. Yeah, let's see. Yeah, so this is what we did. We had to make sure that A, B, C, D are sorted. So we put them on oxygen, 15 liters via an rebreather. We also had to give them fluids. And then we also had to control the pain with either paracetamol and ibuprofen, usually in sickle cell, because really they have severe pain. We use these analgesics alternatively. We alternate them. So we alternated between IV paracetamol, oral ibuprofen, and then oral morphine. And that was our supportive management. In the specifics, because we know that we wanted to establish the hemodynamic states of this patient. One of the things, and also reduce on the vaso-occlusion, because you know that blood transfusion is one of those things that is going to help us reduce on the sickle cells within the body. So we transfuse them with red blood cells, 1 unit. And usually in acute chest, our target is 9 and 10. We target to have an HB of 9, between 9 and 10. We also started them on IV artesunate for the malaria. And then specifically, we put them on a macrolide, that is azithromycin, and then IV ceftriaxone to stop the sepsis. So in our follow-up plan, because we realized that this was a 9-year-old and this was the first time the diagnosis of sickle cell disease was made. So in our follow-up plan, we intend to start them on the routine care, routine medication, which include folic acid, Fancida. Folic acid is daily, then Fancida is usually monthly. And then we also now need to initiate them on a wonder drug, and that is hydroxyurea. Which we shall do at 20 milligrams per kg. We will also enroll this child into routine care at the sickle cells clinic. And then there's also need for us to screen them for asthma and COPD. Then it's also key for us to do chest physios for this child to improve their lung function. And then we need to counsel the parents on their reproductive plan, because the possibility of getting another child with sickle cell disease is 25% of every pregnancy that they get. Thank you.
Oh, yes. Thank you so much, Dr. Segawa Lawrence, for that wonderful presentation. So now this is from the audience. Is there anything else you would like to know from Dr. Segawa before we proceed on to the next presenter? If you have a question that you particularly want Dr. Segawa to make clear, you can go ahead, type it out, or raise your hand, then you're picked upon, then you are unmuted, and then you ask your question. Do that very fast so as we move on to the next presenter. Thank you so much. Yes. Mera Akero.
Yes, please. Thank you very much. Good afternoon to all. Thank you for the presentation, Dr. Segawa. Mine is back on the X-ray. I don't know if I missed it, but I wanted to understand more what you thought the opacities were, and just a slight clarification on the X-ray, because sometimes in sickle cell, I feel like the X-ray can be a bit confusing. So just throw a little more light as we move forward. Thank you.
Thank you so much, Mera. Any other hand? I would want to only pick two, then we move on. If there is none, Dr. Segawa can go ahead and address.
Okay. Yeah. Thank you so much. That is Mera.
Yes.
Yes. For the question, back to the X-ray. I just wanted to do a summary of what is happening, but I wanted to appreciate the lung fields, okay? Because it's clear. So you realize that within the lung fields, especially look at the middle lobe, right? Around the middle lobe, you're going to see infiltrates, right? Those white spots right there that the cursor is pointing at. On the middle and the lower lobe. Yes. Then the same picture is happening on the right side, okay? Yes. So, yes, right there. So in acute chest, we look out for these lung infiltrates. Someone can call them homogeneous opacities right there. Yeah, so those are some of the key things that will help you to make a diagnosis of acute chest syndrome in a child with chest pain and difficulty breathing, who is also a normal patient of sickle cell disease. So I hope that makes you understand what we are talking about. Thank you.
Oh, yes. Thank you so much, Dr. Lawrence. Of course, it works better if someone had already basically an X-ray that you now see presence of a new infiltrates. But in our case, that's the X-ray that you have. You go with what you have at hand. Yeah. Thank you. So, for the interest of time, allow me invite another presenter, and that's none other than Miss Ikirol Bessie, a registered pediatric nurse at Cure Children's Hospital, and then she will be taking us at emergency nursing care for a child with chest pain. So this is very, very important. You need to pay attention that you actually do not miss on what is specific to this case. So, Miss Bessie, you're so much welcome.
Hello, good afternoon. I hope everyone can hear me.
Yes, please, can hear you well.
Okay, so we are going on to the nursing part of the management of our patient that is in IPD. And I've put some nursing diagnosis as a nurse, what you have to look out for, because for you to manage a patient, we have to have the diagnosis, like what are you focusing on? So I've put some slides. I don't know if they can put them up. Is it okay?
Yes, please.
And we can skip the introduction bit of it and we just go straight to the slides because of time.
Please go ahead.
Yes. So we're looking at, because usually when we are assessing our patients, we are going through ABCDs. So number one is on our assessment, we have chest pain, we have tachypneas, we have crackles, and we have cough. So here we are looking at, when we get our diagnosis, it is impaired breathing pattern. This is an actual diagnosis. Impaired breathing pattern related to lung tissue disease. And we have the evidences already because the child was able to verbalize the chest pain. Then we had the tachypneas and crackles, plus also cough. So our goal, what is the outcome that we want to come out with? So after the intervention, we want to see that the patient is actively participating in actions like deep breathing, exercises, and also want to see improvement in our work of breathing. So our interventions will be to monitor and assess the rate of the respiration, the depth, and use of accessory muscles. Then we'll connect our patient on oxygen. That is number one. That is very important. We have to connect our patient on oxygen. Then we will help our patient in coughing and deep breathing, then also positioning our patient. Then also then the rationale is to minimize the discomfort, because when our patient is hyperventilating, there is a lot of pain, remember, in the chest. So we want to minimize discomfort, help identify the signs of respiratory compromises or muscle fatigue, then also facilitate maximum lung expansion. So on our evaluation, the patient will be able to breathe easily. That is improved work of breathing. Then we'll have also decreased oxygen needs. Then also when you look at the muscle, I didn't put that point, but we'll have reduced use of muscles like sorry, I have issues with my connection. Is everyone able to hear me?
Yes, we are hearing you.
Okay, thank you. Thank you so much. So as I was saying, we'll have our patient will be able to hello?
Yes, please go on. We are hearing you well, so continue.
Oh, okay, thank you so much. So patient is able to do deep breathing exercises, as I was saying, then also reduced oxygen need. And also our vitals will be normal. We'll have our SATs improved because our patient was saturating between 70s to 80s. So our saturation will improve. So we can go to the next. Let's have the next slide, please.
Yes.
Okay, so another assessment that we have here is a body pain and then tachypnea. So I came out with a nursing diagnosis of chronic pain related to vaso occlusion. serocclusive crisis or disease process. So my goal is patient will be able to verbalize decreased pain use when we use the pain scale. So the intervention is monitor vitals, because vitals really play a very good role when we are assessing pain. So we are going to monitor our vitals maybe hourly, depending on the severity of the pain. Then pain assessment using the pain assessment scales, that is maybe between 1 to 10, depending on the scale that we have, that you have at hand. Then we are administering our analgesics as prescribed, as we've seen them already. Then we ensure comfort. Then minimize, then we have destructive measures. These are children, so we can actually minimize pain by introducing other destructive measures, like maybe games, some videos, some pictures, like we need to distract them. So the rationale is guides pain rating and management. So with this, it helps us to know how severe the pain is, and this will direct our management of pain. Then also encourages relaxation and then distraction. So our evaluation is patient will be able to verbalize reduction in pain using our scale. Not like, for instance, can say the pain is from maybe is in 5/10. Then maybe you can just use signs like how is the pain now, depending on the scale that you use at first. Then the patient will be able to sleep without difficulties. That's how we will evaluate. Patient will sleep sound and calm. Let's go ahead to the next one. So another assessment is we had PALA with a lower HB of 6.5. So we have our nursing diagnosis as ineffective peripheral tissue perfusion related to vaso-occlusive crisis. So our desired outcome, patient will manifest hemoglobin level at their baseline. That is what we want to see. So the intervention is transfusion. Then, of course, we have to still administer oxygen, which we already did. Then we can have fluid administration, but with caution, because this is a sickler baby and we have our HB low. So we have to be very, very crucial when we are giving our fluids. So the rationale is enhance the quality of healthier red blood cells. Then we have our evaluation as the HB went up to 7.7 grams per deciliter. Let's continue. Thank you. So another one, this is a risk factor, because since we have a new diagnosis to the mother, so we have a risk for knowledge deficit related to the new diagnosis. So we want our patient and family to be able to verbalize and follow a plan, because when we give our patients, most especially the ones that that are new, or this is a new diagnosis. So we want to make sure that they understand properly what we are telling them and the follow-up. So we need them to verbalize. When you talk to them, sometimes they get distracted, so you tell them to verbalize. Then on our intervention, we have to assess family knowledge and myth about sickle cell disease, because our patient is having sickle cell. So in this particular patient, we assess, because most of them come with myth about the condition. So we want to assess the knowledge, then also educate the family and patient about the disease routine, medication, and review dates. Then health educate about medication. So our rationale here is helps to know what to teach, because when we listen to them, we will know what to teach and how. Then also prevent rebound severe crisis. So our patient and family will verbalize the follow-up plan and then adherence. Then also there is something else that I hadn't put here, is about the nutritional status of the patient, because according to the survey, it was showing that the patient had still. Sorry, is anyone saying something?
No, please go ahead.
Okay, thank you so much. So the nutritional part of the management is very, very important, because we see that our patient last ate like on the 21st. So we have to, if the patient cannot feed orally, maybe we can introduce an NG tube, and aside the fluids. Yeah, fluids are okay, but we don't want to overload the patient. So we have to give maybe put an NG tube if the patient can't feed orally. Then also maybe we can give some appetite boosters to help the patient pick up with the appetite to eat, and then help educate the mother on nutritional like diet, what they have to feed the patient with. For instance, maybe for instance, the feed that can help boost the HB up. That's what I meant. So nutritional wise is very important. Thank you so much. So if there is any other question, I can be able to. Thank you.
Yes, thank you so much, Sister Bessie, for elaborate presentation about nursing care for a child with acute chest syndrome. Thank you for your input. If someone has a question specific to the nursing care that has been presented to us, please do not hesitate to raise up your hand, at least one person. Then you can ask your question, Sister Bessie. Otherwise, the rest can type your questions in the chat and we see how we can gather them together. So don't be discouraged, type your question. Dr. Anna is writing questions here. We shall have a session where the different questions shall be answered. So, but for this particular presentation, yes, Mr. Opio John, we are unmuting you. Please ask your question.
Yes, thank you so much. The previous presenter, mine is an addition on the interventions basically that nurses make, especially when we are intervening on the nursing process. We always emphasize basically the non-pharmacological approach that we shall employ to manage these patients. So in this case, I think okay, the presenter started with oxygen. However, it's necessary to start with non-pharmacological, which is positioning the patient. And then, of course, as assessment continues, it doesn't stop, the assessment continues throughout, but we first begin with positioning the patient, because if, for example, in areas which are not resourced enough without oxygen, what would you start with? It doesn't really help. So we start with positioning. After positioning, we can now come up with other, like for example, we can encourage the chest breathing exercises, give this patient the balloons. We want to achieve compliance and expansion of the lungs. Yes, so what I mean here is that we oxygen therapy comes among the last interventions that we shall do when we are implementing the nursing process. In that regard, of course, the other medications as well will be among the last things. But yes, that's the concern I just wanted to put in. Thank you so much. But the presentation was very grateful and resourceful. Thank you so much. I submit.
Oh, yes. Thank you so much for your input. And is another person? Mera. Oh, yes. Thank you so much for your input. Then Merab can also give her input to a question, then we progress to the next presenter. Merab, who had raised the hand earlier, do you still have the question? It was answered.
Thank you very much. I was still unmuted. I want to appreciate the presenter for what she has given us, and also Set Global for this. It's a very great topic that actually is challenging to us as nurses sometimes. And I just wanted to make a comment to us as nurses, because I'm a nurse, just to emphasize on our management. The presenter has emphasized the nursing care plans, using the nursing process to manage these patients. But I want to remind us that it is something that we need to look at, identifying what the need is first, what is the priority. We need to prioritize the need of the patient at that point, not forgetting what is life-threatening. What is this that if you don't act immediately is going to actually worsen the state of the patient. So even as we align and bring out our nursing diagnosis, we need to have, we have to observe together with discussing with the patient, what is that you think needs an urgent attention? What is that we need to do? And also to echo on what my other colleague said, that as nurses, we don't have permission yet to prescribe certain medications. I think we need to stick to what we are supposed to do, so that we keep in line and work as a team with the doctors. Otherwise, we'll find ourselves going, doing what we are not supposed to do. And somehow, if things go wrong, we'll get into trouble. And then also requesting a doctor to clarify on, I think there's a little bit of challenge on how to calculate fluids to give to these patients. Yes, thank you. Back to you.
Oh, thank you so much for that wonderful input. Mr. Y. Michael has also an input. We could also allow him, hear him what he's saying. Michael, the floor is yours. Is unmuted, right? Still muted. Oh yes, so as we are finding a way to let Mike unmute, Dr. Segawa can actually give us a brief a highlight on how to calculate fruits when you are giving fruits, especially to this pediatric population. Because it's a common thing we do, but how do we do it right?
Yeah, thank you so much for the question. This is very key, especially in pediatrics. We don't just give fluids because fluids also come with a number of other challenges. And those who know that actually in malnutrition, we really restrict them to zero because fluids, studies have shown that they actually accelerate the death of our patients. Yeah, usually what we do is we calculate their maintenance fluids. Okay, and we use a formula which is 100, 50, and 20. For the first 10 kilograms, you multiply by 100. Then the next 10 kilograms, you multiply by 50. And then the next 10 kilograms, or the others actually, you multiply by 20. So when you get their maintenance, you'd want to give maybe 2/3 of the maintenance as IV, and then the other will be oral. Yeah, so that is what we mostly use in pediatric. But also, the other key thing is to also assess whether they are dehydrated. Okay, because if they are dehydrated, then you have to use a different formula. And also, if they are in shock, you would still use a different plan for managing their shock. But if they are not dehydrated, they are not in shock, and you just want to give them fluids, use the maintenance fluids.
Yeah. Do we by any chance know the kilograms of this patient?
Yeah, this child was 30 kilograms.
So maybe for purposes of making it clear to the rest of audience, if a patient has 30 kilograms, how do you use your formula to come to the maintenance fluid?
Yeah, so we say the first 10 kilograms, you're going to multiply by 100 mils.
So you break the 30 kilograms to 10 kilograms and the rest.
And then the rest. The first 10, then the second 10, and then the rest.
Yes. Okay. So 10 times?
10 times the 100 mils.
100. Okay. So you get 1,000.
You get 1,000. Then the other 10 times 50.
So 10 times 50.
You get 500.
You get 500.
And then the other weight that is left is 10. So you multiply the 10 by 20.
You get 200.
You get 200.
So total is 1,700
mils. Yes. So we are going to give two-thirds of this 700, and this is within 24 hours. Okay. This is within 24 hours. So we are going to get 1/3 of this, and then we shall give it as IV, and then the other third you'll encourage the patient to take orally.
So 2/3 is 1.1 liters. So how do you give it? You give it bolus, you give it.
So this 1.1 liter that is left, you're going to calculate it across and decide maybe you're going to give it every 8 hours. Okay, so you're going to divide
by 3.
Yes,
by 3. Then you come to 378 mils.
Okay,
you give
so
it
you end up to give like 370 mils 8 hourly. This child. Yeah.
I think that's been so clear. Thank you so much. And I think this ushers us to another very critical phase where we are going into the next presenter. And now, Dr. Julian Abeso, the senior pediatrician who has been long in practice, will give us a wealth of experience and knowledge about how to manage a child with chest pain, tailored to acute chest syndrome, and also in general, to give us highlights such that the day you will be the one receiving that child, you will be remembering these highlights and you do that child the service. Dr. Julian Abeso, you're so much welcome. The floor is yours. Yes. Dr. Juliana Beso is unmuting and is preparing herself to present. So, as we've seen, fruit management. So it's very, very important. And especially in sickle cell, and please calculate such that you do not just come from one end of hydration and swing to pulmonary edema or congestive heart failure and all that. So fruits are important in management of sickle cell in general, but also they come with a consequence if actually they are not cultivated. And two, maybe another thing that I can pass on is that if someone is saturating, sometimes you just have to tailor your management options to the need that is before you. So please give that oxygen if you have it. Then you can actually organize yourself later. Give that oxygen, don't hesitate, give that oxygen. Follow airway, breathing, saturation, in that order, so that you're not caught up forgetting one. So if the air was obstructed, you organize it. If someone is not breathing well or breathing so fast, give oxygen, whether the doctor is around or is not around. Yes. Dr. Sego. What else? What else do you feel pediatrician should not miss? Especially for others that are not pediatricians, if they are the first people to receive your patient.
Yeah. I think one of the other key things is that you notice that the diagnosis of sickle cell has just been made at 9 years, and this child had very clear features. Like I presented, and actually the child had frontal and parietal bossing. So I think it's very key for us as clinicians to always be out on the lookout. When you notice any abnormality in terms of presentation, let's one, we need to be good at taking history, but also let's correlate our clinical examination with the history, because we are receiving this child with a complication of sickle cell. If we had actually earlier diagnosed it, because hydroxyurea now is a wonder drug, it's a disease modifying drug. If this child was diagnosed, say, at 1 year, possibly would not end up into this. And complications come with a lot of challenges. It's unlikely that this child will restore his full respiratory function, okay, because of this event. And one event of an acute chest will lead to another. Thank God this child did not have a stroke. But so as clinicians, we really need to be keen. We need to be on the lookout for these things and smart screen, diagnose. If you cannot, refer to centers that are higher than you so that you can make this diagnosis earlier and save so many lives.
All right. Thank you so much. And this ushers us to the next presentation, emergency treatment of a child with chest pain in general. So Dr. Juliana Beso, you're so much welcome. Please take on the floor.
Okay. Thank you so much. I hope you're getting me.
Very well.
Okay, that is good. So we are going to look into acute and critical care of management of a child with chest pain. And we want to go through how we are going to manage, because a child who comes, you can't know whether they have acute chest pain, acute chest syndrome, or any other cause of chest pain. So that is why we are going to make it a bit general, because I've also seen on the chart there are a lot of questions around the other causes. So next slide, I'm going to start by reviewing an article. And in that article, the next slide, please.
Dr. Beso, we can't hear you. Dr. Beso, we can't hear you. You muted yourself. Oh yeah, so Dr. Julian Beso is coming, joining in about a minute's time. So let's be patient. So in the meantime, someone had asked that someone who is a seeker, it's uncommon for a child to present at 9 years when it's their index admission. Is it a sort of a miracle that the diseases don't read books, or there are other protective factors that maybe we didn't take away from your presentation?
Yeah, thank you so much. The person who asked questions, that question. There are many theories to explain this. One could be, it's true that sometimes there are different strains and variants of sickle cell disease. Some have severe forms of the HBS and others have less severe forms. But that aside, I think it could have been two things. One, denial of the parents and also the health workers that have been seeing this child serially, maybe when he gets a flu cough, which is not ending up into difficulty in breathing. If this child had not got a difficulty in breathing, maybe we would not have received them in blood. They were from Chitemi, they would have gone to another place. So, like I said earlier, as health workers, we need to be on the lookout. You need to know the presentation of sickle cell, that you can easily just look at a child and suspect. And when you suspect, you go ahead to confirm. The government has rolled out free testing. We're actually even doing newborn screening, yes, in the different facilities. So it's not an excuse for not to diagnose the child early, because the tests are free and they have been rolled out, and the management now is also free. Okay, I've seen a number of children who are doing well on their routine care. They don't have any of these complications. So I think it goes back to us as health workers. We need to do more, sensitize people more, and really diagnose some of these conditions early so that we avoid late presentation.
Yeah. Anyone can produce a sickler. You could be a sickler until you test and know. So test yourself, test your children and your friends' children. Those who are sicklers, enroll them on care, so they have a very good life and prevent the complications.
Yeah, maybe to correct you a bit, Dr. Anderson, we don't call them sicklers because it's a bit of stigma. We call them children with sickle cell disease.
That's very important. Yes. That's why you're here to correct that.
Yes, yes, please.
Thank you so much. Is Dr. Julian back?
Thank you. I think I'm now back on.
Oh yeah, you're welcome.
Okay, sorry about that. They had to remove me from the rights because I was getting a bit of challenges. So in this study, they looked at children who had chest pain. Now, why I liked this study is that it was a systemic review, and it takes us to the next slide. Chest pain in children is actually often benign. Like, children can complain about chest pain, and sometimes it's difficult to know. And remember that complaining about pain in children is a bit difficult, you know, because children may not exactly know where the pain is coming from. So sometimes when they point to the chest. Sometimes they say the heart is paining. Sometimes they say it's the stomach. So it becomes a bit of a challenge. And that is why chest pain may not be like taken so easily in child practice, okay? Now, the next slide will show us the type of chest pain and possible causes. Because if a patient comes in an emergency, you need to point out exactly where the pain is coming from so that you're able to manage the patient appropriately. And like I said, most times it's benign, but it may be a sign of serious illness because in our patient, the cause was acute chest syndrome. Now, the common causes of pain in pediatrics is musculoskeletal. It could be respiratory, like in our case. It could be cardiac, it could be GI, it can be psychogenic. And cardiac causes were already described, so we are not going to go into them. Now, the immediate goal when we get a child with chest pain is to rule out life-threatening causes. Because if you think the child is malingering and it's just psychogenic pain, it might actually be showing to something more serious. Next. So the initial assessment is that we go through the ABCs, like what Dr. Segawa went through, the airway, the breathing, the saturation, disability. Now, as you go through the airway, of course, if it's clear, that's okay. But if it's obstructed, you have to clear it so that you can go on to the next level of seeing the rate of breathing, the effort, the oxygen saturation, because in these patients with acute chest syndrome, many times their oxygen saturations may be a bit low or even very low, okay? It may be below 90. And actually that is one of the signs that can help you to differentiate between acute chest syndrome and pneumonia in a child with sickle cell, the oxygen saturation, okay? Then the saturation. If you've gone through the B's, then you go through the saturation, the heart rate, perfusion, the blood pressure. You try and correct those ones if they are deranged in any way. And this is where you may go ahead and give the fluids. We've already talked a lot about fluids, but in this child, of course, the fluids of choice was the blood, and then maybe followed by saline or whatever. And you know that fluid resuscitation in children can be a bit of a challenge because there is a thin line between overperfusion and underperfusion, okay? Then the other thing you look out for, after correcting the saturation, you go to the disability, okay? Now, in disability, you're looking at consciousness. If the child is convulsing, you can find out whether there is hypoglycemia and correct it and all those things. You don't want to look at the pupils because the pupils will tell you whether there is maybe toxication or whether there's a raised intracranial pressure or not. And next, after disability, you expose the child, you look for rashes, trauma, surgical scars, and so on. You realize that in the ABCs, the most emergency things are the ones you do first, the A, B, and C's. Then now these other ones, you will do them next, okay? Now, if your patient has a low oxygen saturation or is using a lot of effort for breathing and all that, you start oxygen, like in that patient. If the patient is unstable, maybe he has cold extremities, you know, he's unconscious and all those things, kindly shout for help because it means you will need help to put up a line, to do so many things. You can't do it on your own. Yeah, okay? Now, after that initial assessment, then you can go and do a short focused history following the sample, like what Dr. Segawa went through, the symptoms. When did this pain begin? What is the nature of the pain? Where does it radiate to? Now, remember that looking out for nature of pain and radiation of pain is quite difficult in children, because especially for children who are less than 12 years or even less than 6, they may point out to the pain, but they may not be able to exactly tell you that this pain is burning in nature, or this pain is excruciating in nature. They may not be able to describe those things, or dull. They may be simply crying. And this is where we may have to use the pain score for assessing the pain in those children. Then the next thing you look out for is the allergies. Because remember, some allergies can, like if it's asthma, they could actually present with chest pain, okay? Now, then also the medications. Remember, there are some medications which may trigger chest pain. For instance, medications which can cause a gastritis. This chest pain may actually be retrosternal. It may be GERD, or it may be, pain associated with taking certain types of medications. So we have to rule out the medication history. But also it helps us to know the medications so that we can know which other medications to give or to avoid. Then the past medical history is important. Your child might have had, maybe already is a non-asthmatic, and the people who have brought the child know that the child is asthmatic, but because they are scared, they may not, like they are disorganized, they may not even be able to point out that the child is asthmatic at that point, until when you ask for it. Then you realize that it is asthma, but maybe with a silent chest. Because in asthma, you would expect wheezing and all that, but if it is a severe exacerbation, you may get a silent chest. And then for you, you think that maybe it's another cause, when actually it's asthma. Then there are also cardiac issues, but the cardiac causes, we already sorted them out. But there are cardiac problems, like a myocarditis is very common, especially following viral infections in children. They can have a pericarditis, and there are many also post-infectious causes of a pericarditis in children. And then trauma. Please don't leave out trauma, because many times when children are playing, maybe they can get trauma and they be quiet because they are scared of their mothers and so on. So you have to rule out the history of trauma. But remember, in trauma, you can even end up with things like a tension pneumothorax. So that is why it's very important for you to rule out the history of trauma. Then, of course, the other thing is the last meal. When did the child take the last meal? Because it will help you to do things like correct for hypoglycemia, but also it may help you to rule out issues like GERD and all those things. And the events leading to the pain is also important. So follow the sample way of doing a focused history. Remember, your history should be focused. It should be short, because you don't know whether it's an emergency or, okay, you don't know, it may be an emergency and you're wasting time doing a very long history. But eventually, if it's an emergency, you should sort out the emergency things, then you go back to continue with your history. Next. That in order for you to make a decision, you also have to examine your patient. So like you saw, the work of breathing, then signs like cyanosis. Now, a chest deformity is also very important. Many times we leave out chest deformities because we are just looking out for, the work of breathing, the respiratory rate, and so on. And the other things that you have to, as you're inspecting, listen to those abnormal sounds. Maybe the patient is wheezing, maybe is grunting, maybe has a stridor, and those kind of things can guide you and direct you to where exactly to to make your efforts. Now, palpitation. In palpation, tenderness is key because it suggests a musculoskeletal cause. Now, this is one of the things that you can actually find in a patient with acute chest syndrome. And Dr. Segawa pointed out that this patient with acute chest syndrome actually had tenderness. And how it comes about in acute chest syndrome is that, of course, there is vasocclusion in the lung parenchyma, in the muscle, then also even in the ribs. So that is how the tenderness comes about in acute chest syndrome. But remember, there are also these things we've talked about of trauma, they may also cause tenderness. Then there are other causes of tenderness on the chest, and that is why you have to do palpation and elicit for it, okay? But remember, if the patient is tender, you should not concentrate and over make it again more tender. It should be something a bit, don't over palpate. Then the auscultation, look out for the breath sounds, the heart sounds, murmurs, and all those things. Abnormal sounds, so that you're able to point out to what it could be. Now, the vital signs, as usual, are the heart rate, the respiratory rate, the SpO2, and the BP. And these are the things that you should keep monitoring for the vitals as you're going about with your management. They help you to know, for instance, if the heart rate now is maybe in that patient, the heart rate was higher than his age. So if, as you're continuing to monitor, you realize that the heart rate and respiratory rate are going higher, then it means you're not helping the patient. Also, if you're giving fluids and all those things, you have to keep monitoring the heart rate, respiratory rate, especially in children, because you could be going into overperfusion, okay? Then, of course, the SpO2, you have to monitor it. Now, one of the things that helps you to differentiate whether it's a respiratory problem or a cardiac problem is actually the SpO2. If your patient is being given adequate oxygen, the airway of the patient is patent and is being given adequate oxygen, then the SpO2 should go up if it's a respiratory problem. But if the respiratory problem, the SpO2 is not going up and you're giving adequate oxygen, the airway is patent, then you start thinking about a cardiac problem maybe, or any other problem, maybe other systemic problems. Yeah, next. Next slide. Now, this is what we talked about. Many times we forget to look at the chest wall. And it's absolutely important for us to look at the chest wall before we start looking out for the respiratory rate and all those things. Now, there are a number of chest wall deformities in children, which can actually be like they are benign. They can be familial, like pectus excavatum, pectus carinatum. This child in this picture has pectus carinatum. Excavatum is when the chest goes inside. Now, some of those chest deformities are actually familial. Others can point you to certain long-standing problems, like long-standing respiratory problems, long-standing cardiac problems. So you should be on the lookout for them. Then, of course, even scoliosis can cause deformities in the chest wall. And then if the chest is bulging, the chest wall is bulging, you can start thinking about things like, could it be fluid? Could it be air? And then, of course, you correct them according to what you think, okay? Of course, if it's fluid, then the percussion note will be stony-dull. If it is air, it will be resonant. So that's how you differentiate, and then you know how to go about it. Next. So we said that most of the causes of chest pain in children are benign, but this should not make us to start thinking that all children who come maybe chest pain is because it is psychogenic, or maybe it is because they have a diaphragmatic hernia, or it is because they have GERD, or because they have those. Don't always think about causes which are like chronic, where you don't need to act faster. Now, the red flags are if the chest pain is sudden, it is a severe chest pain. That one is a red flag. Because usually the other ones, they are of slow onset, they keep progressing, gradual, sometimes they are there, sometimes they are not there. Then, oh, you're saying I've gone off again? Hello? Hello? Hello?
Yes, please. Yes, please, we can hear you,
Are
doctor.
you getting me?
Yes, we can hear you, doctor.
Someone was saying I've gone off again.
No, it was the network.
Okay. So I was saying that the red flags when to worry is when the chest pain is sudden and it is severe chest pain. But like we said, children may not tell you that the chest pain is severe, but you may just see the child crying, and then you use the pain score to assess the degree of of pain. The other thing is that the child may be having dyspnea or syncope. The child may come when he has fainted, and that is a sign that the pain might be a lot. If there is cyanosis, then it may be pain associated with a severe problem, like maybe a pericarditis and so on. Problems, I had someone asking about myocardial infarction. Myocardial infarction is not very common in children, but in the study that I started with in the preamble, there were very few children with myocardial infarction, and actually the children older than 12 were the ones who mainly came with a myocardial infarction, but the ones below, they had more. And then the other thing is that children who are below 12 tend to have more severe issues than children above 12. And the ones below 12 are the ones, again, who cannot easily They cannot easily express themselves, so they just cry. They cannot even explain. So in children less than 12, chest pain in most cases may be actually severe, okay? Now, the other thing is a history of cardiac disease or recent trauma is also important. For oxygen saturations, we've already talked about it. Next. Those are the red flags. But the common differentials, the ones which commonly come, according to that study, is the musculoskeletal issues, costochondritis, acute chest syndrome. For our case, our child had acute chest syndrome. And asthma exacerbation is also common in our setting. Gastroesophageal reflux, GERD, is also common. Anxiety or panic is common. So for some of these children, you can find maybe it's exam time, or there's a problem going on at home, maybe the parents are separating or what. Instead of saying that parents stop fighting, the child may actually end up with what? With the anxiety and end up with chest pain and non-specific symptoms. Yeah. Next. So the severe differentials, the severe ones, if you see the other severe signs which we talked about, the low oxygen saturations, the cyanosis, the acute pain, severe pain, respiratory distress, these are usually the common causes of those ones, the common differentials. It could be a pneumothorax. In our patient, it was acute chest syndrome. And in our case, a pleural effusion is very common also as one of the complications that you can have here. It can be a pericarditis or a myocarditis, like we talked. It can be a congenital heart disease. Now, pulmonary embolism is quite rare in children, but it can also happen. Of course, there are children who are at risk of pulmonary embolism. By the way, children like the ones we presented, the ones with sickle cell, that one is a high viscosity state. So they are at risk of what? Of throwing emboli at some point. But we also have common cases like children with nephrotic syndrome. Those high viscosity states, they can also be at risk of pulmonary embolism, although it is quite rare in children. Okay, next. Now, the investigations, these ones, you can do them for stable patients. Because if your patient comes and is an emergency, you will do the ABCs. And if you think, for instance, like our patient who came, you're not going to start taking the patient for a chest X-ray. You're going to first begin by taking off blood, do a peripheral film, do a CBC, like the way Dr. Segawa did. Then the arterial blood gases. In our setting, we don't do arterial blood gases, but they are very important for investigating patients with what? Acute chest pain. And then, of course, if you can do a C-reactive protein. I know now most regional referrals can do C-reactive protein. So do emergency tests first. Then these other ones, the chest X-ray, they are emergency, but you may not be able to do a chest X-ray in our setting because most of our settings don't have, they don't have movable X-rays. But if you can do, well and good, because you can see for acute chest syndrome, the common thing about it is that usually it involves many areas of the lungs, and that is why there are so many opacities, because it involves many areas of the lung. And that is one common thing about acute chest syndrome, okay? There are lots of tests that you can do, investigation, depending on what you think your patient has. But remember that for emergencies, first do the emergency tests. Then for stable patients, you go ahead and do these tests when now the patient is stabilizing. Continue. Next. So the general steps, like we did for this patient, ensure the airway is open and there's adequate breathing. If the patient needs oxygen, give oxygen. In this patient, we gave oxygen. Position the child upright unless the child is hypotensive. That's when you will not position upright because it may not be helpful for a hypotensive child. Then, of course, you get IV access, monitor the vitals we have already talked about, start fluids if there are signs of shock, but also for our patient, for sickle cell, they need fluids for reasons that I've already discussed. You need to improve on the viscosity and the sickling and so on and so forth. Then administer specific treatment based on the suspected cause. Now, like Dr. Segawa has already gone through that patient, actually for acute chest syndrome, many studies have showed that there are no specific causes like antibiotics. So bacterial causes, actually many of them are even viral causes, and you know many viral causes are actually self-limiting. So that is why in acute chest syndrome, the guidelines will tell you to give a broad spectrum antibiotic and then add a macrolide because you're thinking of atypical organisms, but it's just because you're trying to what? To cover as much as possible. But you will be surprised that you may not actually be treating the acute chest syndrome specifically. The treatment specifically is that oxygen, the blood you're giving, and maintaining hydration. Then, of course, you treat the cause that may have precipitated it. Like here, it might have been malaria. Yeah. Continue. Now, the specific emergency treatment. If you get a specific problem, like if it's a pneumothorax, you do a needle decompression, insert a chest tube, Or you can, if it's in a place like maybe you're not in an HD or ICU setting, you can just push a needle into the second intercostal space, mid-clavicular line, and then you release the air. But remember that as you're releasing the air, more air again might be entering. So you should put a 3-valve kind of thing so that you have space for air to come out, but also make sure that air is not again entering. Then there are things like a pleural effusion. For pleural effusion, of course, you know that you will have to, first of all, percuss and find where your fluid level is. Then you enter through that intercostal space and pass your chest tube. And then you make an underwater seal drain and drain until when you have drained enough. For asthma, you give nebulized bronchodilators, steroids, oxygen. For pericarditis, you will give analgesic, anti-inflammatory medications, oxygen. But if it is a pericardial effusion, you may have to take the patient maybe to theater or wherever, or if it's an ICU, you can do it in an ICU setting and you remove some of the pericardial fluid, especially if it is massive. If it's a myocarditis, you give supportive care. Most myocarditis is actually viral. So you give supportive care, inotropes, ICU transfer, okay? If it is trauma, you do a chest X-ray and stabilize the fractures. But remember, if it is trauma and it is a tension pneumothorax, you may have to pass a needle, like how you pass in a pneumothorax. Yeah. Okay. This brings us to the specific treatment for acute chest syndrome, which Dr. Segawa has already gone through. So maybe if you have any questions, we shall discuss more. But for now, let's go through this flow chart, which guides us on how to make a decision. Now, if a child comes with chest pain, you can see here, if a patient comes with chest pain, we said you do a fast history specific an examination. Now, if you do that history and you get a positive red flag and the ECG is abnormal, or you get abnormal examination findings. In our setting, doing an ECG may be a bit difficult because many of our facilities don't have ECGs at the acute care units. But you can, if you get abnormal causes, like maybe you get rhonchi, you get crackles, you get all those things, murmurs and so on, then you know that the anorganic cause is likely. So you admit your patient or refer if you're in a lower level facility, which may not be able to handle. However, if you get a positive red flag, like your patient is in severe respiratory distress, then the ECG is normal, the examination findings are normal, then most likely organic causes are unlikely. It could be any other cause, but you cannot discharge this patient because already the patient had a red flag. So it means you should admit that patient or refer to another place where they can do further investigations. Because if you just send that patient home, you may get problems, okay? Now, if there is no positive red flag, like the ones we talked about, they are stable, then you do examination, you do a history, there is no specific history. Maybe it's a psychogenic cause, maybe the parents have separated. Now, remember, if it is a psychogenic cause, for instance, depression, and you elicit issues like suicidal tendencies, then it becomes an emergency. So that one should also be admitted. But if the patient has psychogenic problems and they are not having other issues, then you can actually reassure the parents and discharge, and of course give them a review date, okay? Now, presence or absence of red flags from the history or examination will determine whether you're going to admit the patient or not. And on discharge, you discharge the patient according to what they presented with. For Dr. Segawa, the acute chest syndrome, you had the discharge plan. The discharge plan was counseling the patients because it was the first time they had made that diagnosis, and preferably starting the child on hydroxyurea, preparation for hydroxyurea, because this patient is at risk of getting another acute chest syndrome. And the other thing is that you start those prophylactic medications, antimalarials, folic acid, and so on, encouraging them to drink more and keep coming for the follow-up clinics. That is for acute chest syndrome. But in the event that it's something like, for instance, a pleural effusion, and maybe you've discovered that the pleural effusion is because of tuberculosis, then the discharge plan will be different. After you've removed your fluid, you may go ahead, you will start, of course, and then they will start management for TB. Then you will trace for contacts for TB. Then you will also give them a review date, and so on and so forth. So that is how you go about those decisions. Next slide. Next slide. So the way forward depends on what you get. Admit the patient to hospital or ICU if it's serious or if it's unstable. Refer the patient to a pediatric cardiologist if you think it is a cardiac cause. Okay? In our setting, you can refer the patient to a pediatrician. Then the pediatrician will see the patient and decide whether to refer to the cardiologist. But in a setting like Mulago, where cardiologists are there, you can just refer to the cardiologist and then they'll decide. Okay? Now, if it is musculoskeletal, for instance, if they have scoliosis and they are getting pain because of the scoliosis, then you have to reassure the patients and the child and tell them that it's because of the child's, the way they position, their posture. That's why they are getting pain. If it's anxiety, like I told you, counsel the patient and see how to follow up. But again, I've told you there are some of these cases like depression with suicidal tendencies, which are emergencies. Okay, next. So this is a scenario. If there is a 10-year-old child who presents with chest pain after soccer, mild tachypnea, normal SpO2, what is your differential and what are your next steps? Maybe we can give like one or two people to give us their views, and then we discuss and we close this. Any volunteers? A 10-year-old boy with chest pain after soccer. He has mild tachypnea, but normal SpO2. What are your differentials?
Definitely, I don't choose this.
Hey, okay, Harriet, maybe you should unmute Harriet and she shares with us. Hey, is it Harriet or Herbert? Herbert. I'm sorry, I called Herbert Harriet.
Some people usually do, but yeah, I soccer match. They could have had some maybe trauma. Yeah, so I think that would be that line.
Harriet, we are not getting you very well. Harriet, oh, Herbert.
Herbert,
There are many answers here. Some are saying asthma, others a myocarditis, others a short QT interval. Okay. Someone said trauma. Okay. Now this brings us. Thank you so much for your. Thank you so much for your answers. You can see that there is a wide variety of answers. But what I wanted to bring out in this is that you go through the steps very well, assess, are there any danger signs? Are there any red flags? And from here, this boy has a mild tachypnea. Why should he be having a tachypnea? Okay, so that is actually a red flag. But then you will need to what? To investigate him. This is a child who may give you chance to do those tests like a chest x-ray, like an ECG. Then of course, after you have done your history, maybe you elicit for what? For trauma and all those things. So that is how you go about this. I hope I've given you an idea. Okay? If it is not clear, you will ask in the chat. So all of you are correct, but I would like you to go through the steps that we've gone through so that you will eventually be able to do what? A diagnosis, because the diagnosis will
Oh, yes. Thank you so much, Dr. Beso. Thank you. Has been an elaborate presentation, very educative, and I hope all of us have learned a thing or two or three. So, for the interest of time, we shall launch post test questions on your screens. Then, as the experts, we shall give each about half a minute to tell us one take home, that if everyone forgot all those words, what should they not forget? So, but in the meanwhile, there is a poll on your screen. Read the question from the history and primary survey. What are the two most eminent emergencies in this patient? And then you choose. So literally we're trying to see that, yes, you've had the presentation, you've had the teaching. Now we want to see the application of knowledge in the post-test. Yes. I can start with Q&A. So in the meantime, let me welcome the most esteemed Dr. Anna Kaguna, take us through a period of question and answer. Many people have asked questions and she must have noted some. Then she will see how she guides us along.
Thank you so much. Thank you so much, the earlier presenters, Dr. Peso, Dr. Segawa, Dr. Joseph. I think the questions have been well answered in the chat. And most of the questions that were asked, right from what are the expectations from this session, emergency assessment of a child with chest pain, that has been handled well. I don't think I need to recap anything. Radiological investigations have equally been highlighted quite well. The question that stood out is someone wanted to know what would be the psychological management for parents that are having a child with acute chest pain. Obviously, being an ED doctor, I would put it in the context of the emergency department. Sometimes in the emergency department, the presence of a family or a mother is important. And as we are as you're managing the child at every step, it's important to actually reassure, talk to the parent about what the next step is in care. But when it comes to the depths of psychological care, that will be done outside the acute care setting. So most likely like Dr. Segawa gave us a follow-up plan. So discussing, this is a child that has newly been diagnosed, for example, the case we had, sickle cell disease. So that would be a follow-up plan to manage them psychologically, to accept the diagnosis, and then the follow-up of these children. So psychological management may not be exactly done in the acute care setting, but we can reassure the parents, explain to them what's going on to the child, and then whatever has remained, you involve psychiatry and psychology team to handle the parents. Yes, and then the other question that caused a lot of debate in the queue was for this particular case that the child that was presented. Why did we say that it was complicated malaria, yet the parasitemia was +1? So it caused a lot of debate. I think we're going to discuss it with Dr. Segawa in a minute. But in this case, severe malaria is not only diagnosed with the level of parasitemia. There are complications of malaria that are listed very well in our guidelines. But among them is this child had acute respiratory distress syndrome, which could have been from the acute chest syndrome, but it can also be because of the malaria. We had anemia. We had, what else did you have in this child? Hemoglobinuria. Yes, we did have this. So there were other signs, associations of malaria that qualified it to be complicated malaria, even with a parasitemia of +1. Yes, I think those are the things that stood out. Most of the other questions were attempted to. Yes, thank you. Dr. Sega, is there anything else?
No, I think you've said it well. There were quite a number of other complications that qualified it to be severe malaria, not just the hyperparasitemia. Yes.
Okay, that's it.
Yes, and this leads us to the last part of the session, asking experts, what should we not forget from all your presentation, from all that fire hydrant that you've given us? What's that drop that we should not lose? Starting with Dr. Sega.
Yeah, thank you so much, the audience. Key things as a pediatrician in making, it's very important for us to be on the lookout as we manage children. Let us be very careful and observant to make sure that we don't miss out on a few clues that they are presented, and then we can manage them well and refer them appropriately. Thank you.
Thank you so much. Sister Bessie, of all the things you've taught us, what should we not forget in just half a minute?
Thank you so much. It's very, very important for us to pay keen attention when assessing our children, because we might forget to, or we might leave out something very keen, like colors, like because when you're looking at the patient, you might find that the patient is very different from the vitals. So we really have to do deep assessment of our patients. That's what I wanted to say. Thank you.
Yes, thank you so much, Sister Bessie. Now, to our esteemed Dr. Anna, what's that thing that you feel should not be forgotten from this eco session?
So what should not be forgotten from this eco session is that let's learn to, children are amazing. So let's treat the child and not get stuck on the diagnosis. Sometimes you might think it's sickle cell disease, but actually the child is having something psychogenic. So let's treat the child and not just get stuck on the diagnosis. Yeah.
Oh, yes. And finally, Dr. Abeso, what's that thing that all of us should not forget in just 1 minute? Oh, yes. Maybe I can give what I really think we should not forget. What you should not forget is that actually the patient that may come to you may not be having acute chest syndrome. So to always remember of other possible differentials. Like, and once you remember the differentials, then you go through the algorithm that Dr. Beso addressed to us, such that you manage a patient based on what is in front of you, not based on what you already fixed your brain on. Your patient could be having another cause of chest pain, not necessarily acute chest syndrome. And in case it is acute chest syndrome, good what to do. Thank you so much. Dr. Solomon Okil on? Dr. Solomon Okil on? Thank you so much, everyone, for attending this 99th ECHO session. It's been amazing, been a great participants, you've been active. Most of your answers were correct, and you've been engaged in the conversation. We all meet these patients, they come to us, and it's very important to know how to deal with them. Thank you so much. These ECHO sessions are usually bi-weekly. Always endeavor to tune into them. Knowledge is never toxic. Keep updating your knowledge every time you get a chance to do that. Thank you so much.
Thank you so much, Dr. Joseph Ayindisiwe, for moderating the session. And I really want to add my voice in thanking the panelists that we've had today. I think the session has been great. There's been lots of engagement. Everyone has learned. And I'm very sure that our children are going to get much better care with effect from today. We've learned how to calculate the volume of fluids with consideration on patients with acute chest syndrome. We've been discussing about if a child came with pulmonary edema, about if a child is having pulmonary embolism, how should we go about fluids? And I think that that is quite an important engagement when it comes to managing children. This has been our 99th ECHO session, and that means that we're making a milestone as ECHO initiative. On the 12th of September, we shall be celebrating 100 ECHO sessions, and this has been made possible by the people that have consistently logged in, the goodwill of our panelists, and the Ministry of Health support, the partners support, and we can't wait to have that 100th session of the EMS ECHO session. It shall be a simulation, and we've put together a panel for expert simulators that are top-notch in Uganda, and you just can't miss that session. I know it's going to be quite phenomenal for ECHO session, and we look forward to having all of you join in for our 100th session as we celebrate the milestone together. We kindly ask you to put on your videos. It's time for us to take our snapshots, screenshots for us to share and keep memory of the time. Meanwhile, there will be a survey sent to you on our different platforms. Just feel free to fill in the survey. It helps us to improve our delivery and what we need to be tailoring our sessions towards. Otherwise, we thank you and look forward to hosting you again on the 12th of September.
Kindly turn on your video. Now it's not restricted.
Sure.
Let's take a selfie together.
Sure. You can share that on some. Can share some people's names.
Yay! Thank you.
I see Susan Minyoro there, looking out for some faces that I know. Wow.
Sanya Jocelyn, thank you so much. Herbert Mutumba, thank you so much. Bashir, thank you so much. It's been great having you. Do it every time we have ECHO session. Thank you, thank you.
And they can unmute and also say what
You can say something. You can also take a selfie and a screenshot wherever you are, so that you keep this as a memorable day.
Our simulation shall be about a patient with respiratory distress. and still quite linked to that session that we have discussed today. And I don't know how many times we encounter a patient with respiratory distress in our emergency wards, even in the inpatient wards. So it's going to be quite exciting, and we look forward to that session. Please do not miss the session. I know it will be quite impactful. Sure. All right, thank you all.
Yeah, thank you, the presenters. I think there's something that was in the